My goodness, such a well-mannered group. I was just looking around and everyone became silent. First of all, we'd like to welcome each of you here. And this is such an important group, such an important collection of people from our community. As I think everyone in the room knows, these are events that we hold for our very special supporters of the Swedish Cancer Institute and of Swedish. And although I've met most of you in the room, I should probably start by introducing myself. I'm Thomas Brown, Dr. Thomas Brown. I'm the not-so-new executive director of the Swedish Cancer Institute. This is my second summer in Seattle and enjoying it very much. I want to thank again each of you as members of the Summit Club. Could I have the members of the Summit Club raise their hand, please? Excellent. And of course, of the Founders Circle. Can I have Founders Circle members raise their hands? And again, very special guest. And Legacy Partners. Very special guest. Thank you again. So, again, the exciting things that are happening at Swedish and within the Swedish Cancer Institute could really not be possible without your support. And at the end of the day, the way all of us make our worlds work on a daily basis is to remember that it's all about our patients. It's all about the patient who's standing in front of you. So we have a very interesting format today, and the intent is for this to be very interactive. And what I'd like to do is to make a few introductory remarks, and then I'm going to introduce our panel. Really, these folks need little introduction to this audience, but I will introduce them nonetheless. And we'll start out with a few comments in response to some general questions, and then we'd like to engage you in asking, not only asking, but commenting on things that are at the top of your minds with regard to personalized medicine. The title, of course, is What Does Personalized Medicine Mean for You and Your Family? And at the risk of being a little repetitious, I'm going to briefly summarize the case for personalized medicine, and more importantly, the excitement that all of us share in living during this time. I know that most of you have heard me say that, most of us in this room have been around long enough to recognize inflection points in history that we've either learned about or lived through. And one of those, certainly in medicine that's so important, is the development of modern antibiotics, of vaccinations, which really led to children living into adulthood for the first time. And when we, on a regular basis, routinely living into adulthood, when you hear that nowadays, it seems absurd. But there was a time when that wasn't assumed, that a child would live into adulthood. Then fast forward to imaging. I can remember as a young physician when the first CT images were being shown, the first time you could look inside of a living human being. And that was incredible. I mean, no one had really imagined, maybe on Star Trek, but no one really had imagined that kind of tool to help us care for our patients. Well, I would argue that we're living in an era that is similarly, if not more impactful. The current era of genomic medicine, precision medicine, targeted therapy, however one wants to couch that. But what it's really about is recognizing in cancer, as an example, that, and I really do believe this, that within about 10 to 15 years, those of us who practice cancer medicine in various forms will look back and will say, gosh, that was really fairly antiquated, the way we would approach tumors based on where in the person's body the tumor started. So we would generally approach colon cancer patients the same way. We would treat patients with breast cancer in generally the same way. Yes, there are variations by stage and so forth, but there were a set of principles that relate to that area of the body, likewise lung cancer, etc. But we're now going into a future where it's more about the unique characteristics of the individual's tumor, and in time, the unique characteristics of the individual, the person's genotype, so that it will be more about looking at that molecular signature of the person's tumor, looking at their own molecular signature, their human genotype, and devising not only treatment strategies, but prevention strategies and risk detection strategies and survivorship strategies based on that personalized approach. And again, some people will say, even you'll hear occasional doctors say, well, yes, maybe someday. Well, actually, no, it's happening now. There are drugs in cancer medicine that we use for certain molecular signatures, if you will, and not for others. And day by day, the number of molecular targets, changes in the genetic code that we identify with treatments, that number is increasing. The number of available targeted therapies is increasing. So this is a very pivotal time in the history of medicine, and that's not exaggeration. It's an exciting, exciting time. But with that excitement comes some uncertainty. There's a challenge to it all, both in the medical context as well as the economic context, as well as the ethical context. And we'll get into some of those issues today during the hour. So the last comment I wanted to make is, we at the Swedish Cancer Institute, we are a hybrid institute. We're a non-university research practice. In cancer medicine, a sign of quality is to have access to the most modern clinical trials, the most up-to-date therapies that are usually evaluated in a research context. So we're a non-university research practice, and we've come up with a formulation. We went through a strategic planning process that was very inclusive. Many of you in the room participated. And we came up with a formulation of personalized medicine with a dual meaning, a double entendre. On the one hand, yes, the molecular signature being obtained of one's tumor and using that information to help, to assist another tool in helping care for the patient. But then the other legacy here at Swedish, we would argue, is the holistic approach to patient care, caring for the whole patient. And that's the equally, if not more important aspect of personalized medicine. So including aspects such as social services, palliative care, integrative medicine, oncophysiatry, and I could continue on, in the care of the patient, their family, their caregiver network. So that's the framing of our discussion today. Was in fact awarded the inaugural Physician of the Year award here at Swedish. We won't say how many years ago that was. She, along with several of our panelists, has been recognized as a top doctor in Seattle. Pat is from New Jersey. She graduated from the University of Medicine and Dentistry of New Jersey, which I believe is now Rutgers, and did her surgical training also at the University of Medicine and Dentistry, and then her breast surgery training at Virginia Mason. And she's a very accomplished individual who also has a doctorate in human and organizational systems from the Fielding Graduate Institute. So Patricia is a breast surgeon, and her perspective on all of this is important from the surgery standpoint, but also she's one of our leaders in addressing with you the patient experience. To her immediate left is a gentleman who in this community requires virtually no introduction, Dr. Hank Kaplan, who, in the most important sense is the physician's physician. And I've known of Hank some over the years, but I've got to know him very well over the recent year and a half, and I understand full well by why so many people, when they're faced with a health challenge, the first person they call is Dr. Kaplan. Hank is a nationally prominent medical oncologist. He's a general oncologist, but with particular expertise in a range of areas, to include breast cancer and hematologic malignancies. Hank is also from the East. There's a theme here. He went to medical school at the University of Rochester and was a resident at the University of Washington in internal medicine, and then returned to Bethesda to do his cancer training at the NCI. And since that time has really been at Swedish. Hank is the leader of our 25-member hematology oncology group that spans the entire 7-site Swedish Cancer Institute network. And to Hank's left is one of our very special clinicians, Dr. Tanya Wahl, who is one of our most dedicated clinicians and someone who is helping us evolve that research platform throughout our network. Tanya is, again, comes with impeccable credentials. She obtained her medical degree at Duke University and her medicine residency at Stanford, and then her hematology oncology fellowship at the Fred Hutch and at UW. But Tanya has brought an energy and an insight into the applications of personalized medicine to medical oncology practice that I've really appreciated. And it's maybe it's the insight of youth. Next is David Corwin, who is president of CellNetix. And you know, one of the virtues of the Cancer Institute is that it's a complex but very well aligned matrix. And by matrix, I mean that we have providers, scientists, and other professionals who aren't necessarily employed by Swedish. They might be in a private practice. They might be working for another institution. In the case of CellNetix, it's a superb academically oriented pathology practice that has been a historic partner, exclusive partner with the Swedish Cancer Institute in providing pathology services. In cancer medicine, the tissue interpretation is key. And now that's evolving. It's not just looking in a microscope, but it's actually looking at that molecular signature that we're talking about. So David also has lovely credentials, and I should mention he is the Chief of Pathology and Director of Laboratory Services here at Swedish, in addition to his position at CellNetix. Has been recognized as well as a top doctor in the Puget Sound. Is a graduate of the University of Michigan, which is why I wore this tie today. And also did his pathology training at the University of Washington. So again, an expert panel. And what I'd like to do is to start out by teeing up a couple of questions for our panel and having them give their perspective, and then would invite you to comment on their comments or to ask follow-up questions. Just raise your hand or shout or do something that will attract my attention, and I'll respond appropriately. So, Hank, why don't we start with you? From your perspective, what is it that has allowed us to get to this point with genomics and molecular pathology? And we'll follow up with Dave on some of the technical aspects, but can you give us some idea of the sweep of medical history that's gotten us to this point?
Well, I think it's an evolution of things that really goes back a long way. As you mentioned, in the past, treatment for cancer has always been extremely empiric, totally trial and error, and it's been based on, in essence, classical pathology. You have a colon cancer in front of you, you find out what works for colon cancer, and you treat everybody with colon cancer that way. That's no longer the case, necessarily. It's still the initial principle that you look at, but we've gone from point when I was a medical student and a research fellow, the level of expertise that we had was looking at chemical pathways. How does sugar get used in a cell, how do proteins get used in a cell, all things that are universal to all cells. And from there, in essence, it came with the discovery of DNA and Watson and Crick, and moving on to figuring out that cells evolve over time. And this is stuff that really occurred more in non-human systems and animal systems, and eventually a recognition that cells evolve over time, the genes mutate over time, and not only that, even within the given genome, cells have all kinds of switches that turn genes on and off. And this has been going on not only in cancer, but in every other field. Some of you may have seen there was one that made headlines in the New York Times about 3 weeks ago, a child that was dying of an undiagnosable brain infection, been in a top institution in the world, been worked up for 3 weeks, and the child was dying, and they got a fragment of spinal fluid and showed a fragment of DNA which identified the bacteria that was causing the infection. Child immediately got put on antibiotics and walked out of the hospital 3 weeks later. So this is not unique to cancer. It's really the ebb and flow of scientific evaluation. We've in breast cancer talked for years about things like estrogen and progesterone receptors because we know that breast tissue is very hormonally sensitive, and then HER2/neu came along and we developed drugs like Herceptin. These are things that we've taken for granted in breast cancer for 15 to 20 years, but as the science has grown, and David could comment on this, and we have a progressive ability to look at further and further into the genomes and determine what makes cells tick, it's become apparent that for certain tumors, genetic changes sometimes drive growth. And so we've been able to take advantage of that and attempt to develop treatments based on what we see driving cell growth. I think one of the major challenges going forward is going to be we're getting so good at genetic analysis that we can find a ton of mutations in just about anything that moves. The question is going to be which genetic abnormalities are important and which ones can we attack in order to
the wheat from the chaff. Mm-hmm. So following up on those excellent comments, Hank, Dr. Corwin, can you tell us a little bit about the 68-item gene alteration panel, maybe walk us from Hank's comments to the development of the panel?
Sure. As Dr. Brown suggested last summer, we began working in collaboration. I think that's very important. In collaboration with the oncologists at SCI to develop a panel of genes that would be actionable, that would actually bring data, clinically relevant data, to the forefront that they could work with regardless of tumor type and hopefully have therapeutic options available given those results. And so we have initiated a 68-gene panel by next-gen sequencing, which is a very sensitive molecular tool in which there's replication of the gene products, identification of mutants, somatic mutations that are occurring within the tumor cells. And we have tried to accent within that 68-gene panel those probes, those genes that have actions that can be taken at the clinically relevant level. Some are related to those genes that turn on tumor action and growth and allow them to have an enhanced growth over normal cells. Some are genes that will prevent the cells from dying, the tumor cells from dying, and which may have a target against them. We've also included in that panel some therapeutic options, so that just because a breast cancer may be hormonally driven, individual women may have different sensitivities to tamoxifen, and you would prefer not to have over-treatment, under-treatment, and so they've included some of those genes in the panel. And so we're moving away from categorization of tumors, as in pathology we've historically done, is beginning in the colon and pancreas, breast, ovary, lung, hematopoietic organs, more toward identification of tumor markers that are based on genetic schema and which are attackable from the clinical point of view based on that mode of action.
So, David, thank you for those comments. I do want to introduce someone in the audience, Dr. Dinbin Zhu, who is here. Can you raise your hand, please, Dr. Zhu? Dr. Zhu is one of the scientists, one of the key scientists at CellNetix, who really worked on the technical platform for the 68-item gene alteration panel. Dr. Anna Berry, her pathology colleague, was not able to join us today, but Dr. Berry, who recently joined us from UCSF, working at both CellNetix and the SCI, has also been a key person on Dr. Corwin's team helping to assemble this panel. As we move forward to clinicians, the exact tool that's used isn't so important. It's the information, of course. It's the information that we gather. And right now, the tool that's being used, as Dr. Corwin mentioned, is this NGS, next generation sequencing, that just allows for super fast sequencing of the genetic code in a piece of tissue. But we also have other routine tests like hormone receptor status and other tests that involve immunohistochemistry, other techniques that have been around for a while, that we're going to be adding to this personalized medicine panel. So it will really be a fuller picture, a fuller portrait of the person's molecular makeup. I wanted to ask Dr. Wahl to comment on the information side, because Dr. Wahl has been one of our early adopters of this technology in terms of using the test for some of her patients. And the information, I'd like you, Tanya, to talk a little bit about how the information is presented to the physician, but also to the person who's having the test done through the physician.
When we order next generation sequencing, it's done off of tissue that's generally already been acquired from the patient, usually when they were diagnosed by biopsy or through surgery. And it takes about 2 weeks to come back. And CellNetix does this really nice job of giving us a report that elucidates what mutations they've found, describes what that mutation may mean to the cell, and then annotates clinical trials or drugs that are already on the market that would address that mutation. And so, for instance, if a patient has a mutation in P10, which is one of the molecules that they sequence, then they may be a candidate for a PI3K trial, and it actually has links to the trials that are listed through the NCI nationally. So, for example, I have a patient with a terrible sarcomatous renal cell carcinoma that unfortunately has not responded to standard therapy. And he is probably going to another institution for a trial that's a phase 1 trial that we don't have available. And that's often true with phase 1 trials. They're very small trials, but it's with a sort of first-in-human targeted therapy that a particular manufacturer is starting to look at. And I wouldn't have had any idea that this is something that holds maybe a little bit more promise for him than randomly checking or trying a phase 1 trial. And so it's, that's a place where it can be helpful. It gives patients a more directed way to find a novel therapeutic.
So while we're on that subject of early phase clinical trials, it's probably an opportune time, and then I want to circle back with Dr. Dawson to talk about other aspects of personalized medicine. But before we do that, it's an opportune time to talk about the Reed Family Innovative Therapeutics Unit, and maybe to have Hank and Tanya talk a little bit about what that is and what it will be dedicated to.
Well, the Reed unit is going to be in the Arnold building on the 4th floor, and it is going to solve some just basic space problems for us, first of all, because we need to expand. But the added value to that is, as we get into this kind of treatment more and more, you're getting to the cutting edge in terms of drugs. All these new mutations we're finding, all these new gene activity abnormalities we're finding. This is all brand new stuff, and for most of these things, quite honestly, there are not a lot of drugs out there for these because the pharmaceutical industry is churning away like the hamster on the wheel, trying to develop new drugs. Every time we come up with another target that we'd like to hit, then you have to have some kind of drug to go after the target with. And this is pretty much all new ground. It's non-traditional area. These are rarely chemotherapy drugs. These are usually drugs that inhibit a specific biological process that the gene mutation dictates. And, you know, we could spend the whole time on how the pharmaceutical industry and the FDA has had to reorganize itself in order to do this. It's a fascinating story in and of its own. But the bottom line is, if you're going to be able to attack these new targets, you're in essence going to be talking about using new drugs. And to do that, most of these will be on clinical trials. And the entire country, again, is reorganizing how it does clinical trials to speed up this whole process. And you need a unit that has the capability of dealing with new drugs. So that means being open 24 hours a day. It means having specialized physicians and specialized nurses who can deal with these new drugs, who can perform these protocols, who have specialized knowledge. And the Reed unit is going to be able to do this. This will be a facility that will be open 24 hours a day to take care of patients. There will be special training for the people who are going to be there to cope with both the specific care of the patient as well as the regulatory needs to make these new target drugs available to patients long before they're ever going to get approved by the FDA.
And the challenge that Dr. Kaplan just alluded to, it relates to this transition from thinking about cancers in terms of where they started, the colon, the lung, the breast, versus looking at that molecular signature. So in the past, when a new cancer drug was being studied, we would generally look at it in everyone with colon cancer if there was some reason why we thought it might work in that particular group of patients, or everyone with lung cancer. Now, as Hank alluded to, it's going to be matching patients to a particular new drug based on molecular signature qualities. Again, initially of the tumor, but probably within a few years we'll be routinely, in some cases, routinely looking at the person's genotype, which is the other side, not just the tumor's molecular signature, but the person's molecular, their innate molecular signature. So to switch gears just a little bit, I'd like Dr. Dawson to maybe comment on two issues. One is, Pat, from a surgeon's perspective, because a lot of times with hematologist, oncologist, and there are three of us here, we think of these molecular profiles in the context of selecting a drug. But give me your perspective on genomic medicine from the surgical side or the multidisciplinary side.
We acknowledge that cancer care for most patients is very multidisciplinary, and every specialist has a role in the treatment. In breast cancer, in our system, the first contact for most patients is with the breast surgeon, and so it really behooves us to understand the whole trajectory of care, because there are some times when it's much more appropriate for the next step for the patient to see a medical oncologist and not go straight to surgery. So we really need to know what are the options available for that patient, what are all the decision points, and how we can get them to the right place. We are usually also the ones that have the first access to the biopsy tissue, and so we can help make sure that the appropriate tests have been done that are going to help direct that care for the patient. So I think it's broadened the things available for patients, and it's broadened the knowledge that we all need to know as we direct care.
And secondly, Pat, I'd like you to comment on the other meaning of personalized medicine, the holistic approach to the care of the patient and their extended family.
So obviously the genetic genomic piece of personalized medicine tells us that there's not any one-size-fits-all paradigm for taking care of patients. But we also know that when we take care of patients with cancer, we're taking care of whole people. And so cancer impacts everything in a person's life. It impacts their family life, their work life, how they feel about themselves. Even when the treatment is completed, there's still an impact from having had a cancer diagnosis. And so I think we're getting much better about trying to understand what are all the pieces of that, what are all the areas that we can do better in assisting folks as they go through a cancer diagnosis. And so for people who are under active treatment, we have things like our cancer rehab program that looks at addressing issues like fatigue using dosed exercise. We have our outstanding social work services who help people with all the logistics of care as well as dealing with the emotional impact of care. We have art therapy, we have naturopathic physicians. So we really want to look more globally at what does the episode of care do to a person as they're going through it. And then with the survivorship program, how can we support people when they finish care? Because we used to just say, well, your cancer treatment's finished, now go live your life. And we understand that there are long-lasting impacts that we need to address, and so we're really working on getting those issues addressed.
So how do we define survivor in the modern world of cancer care?
We, as an institution, would like to define survivor from the time of diagnosis because we think it's a mindset that we should have. We are going on the trajectory of developing survivors. Sometimes patients don't always see that. It's a little bit harder for some folks as they're going through treatment to see themselves as a survivor. But really, we want to be addressing the issues that are going to help make survivorship be successful as well as make the cancer treatment be successful. So, for example, if we don't treat fatigue as it's happening during treatment, that may go unaddressed and just build up over time. Or if we don't treat the physical limitations that may result from the care, the surgical treatment, immobilization, the restrictions from radiation therapy, if we don't address that right at the time that it's occurring, those things may be magnified or maybe fall off the radar screen and not get dealt with later on.
Those are all interesting comments in terms of some of the major issues that surround personalized medicine. Any questions or comments from the audience? Yes, yes, sir.
You started out by saying prevention and detection were important, and I haven't heard much about the prevention part so far. Sort of the detection after somebody is diagnosed with cancer. What do you see in the way of prevention? And it sounds to me like these tests are really expensive that you're going to have, and how does that fit in this?
Well, there are two main questions in your question, so let's take the first part. And would anyone like to tackle the issue of risk assessment, prevention, early detection, and genomic medicine?
Probably give you a couple examples right off the bat. One, of course, is in breast cancer. You're probably very well aware of the huge debate going on as to what's the appropriateness of mammography, how often should people have it, who should have it, things like that. If you have a genetic analysis done, if you can now uncover women with differing risks of developing breast cancer. And I think the way that the mammography debate will eventually go worldwide is that we will stratify women by their risk of developing breast cancer and tailor detection programs for that. Another good example, it's being shown now in colon cancer, that people have certain genetic mutations, have certain risk of developing colon cancer. So those patients, again, can go to screening in a different way. And secondly, in families where colon cancer has developed, they're now showing there are certain prevention strategies that will work. depending on what the genetic makeup is of the colon cancers that are found. A trivial but spectacular example is the use of aspirin, where there is now tremendous data out there suggesting that you have a certain kind of genetic makeup to these colon cancers. Aspirin is an extremely effective preventive drug. I think more and more of that is going to happen as we go forward.
And that this is it's a terrific question comment, because it emphasizes that genomic medicine is not a panacea, but it's a tool that can be used through the entire trajectory of disease. In this case, we're talking about cancer. It can be used in assessing risk, identifying populations at high risk that might be the focus for certain screening procedures. And Hank gave the example of mammography. So it really is an approach that can inform management over the entire spectrum. I wanted to come back to Dr. Corwin regarding the expense piece.
So we've tried to address this. I think we've done a very good, cost-effective approach to even the most expensive of the tests, which is next-gen sequencing. And, for example, the list cost of running those 68-gene assay is set at $2,400. That's list cost. That will actually be pared down to those patients who are self-pay or to the hospitals at a discount of a significant 25% or so even less. And when you take into account the cost that many of these, not just the targeted chemotherapy agents are, they can run $10,000, $20,000, $30,000 a month at times, let alone the toxicity associated with that. I think is a critical importance. It's vital that the drugs, especially that are this expensive, are used in the right setting for the right patient where you expect or hope for a response. If they don't have that genetic mutation, it's probably not worth either the cost or certainly the toxicity. And even routine current chemotherapy is extremely expensive, radiation therapy. If we can identify which patients are likely to benefit, as I think Pat Dawson would attest to, tremendous number of women with breast cancer are treated adjuvantly, and yet they probably are not the greatest portion of those would not be expected to need it. They probably haven't had spread of their tumor, but we don't know which patients are at the greatest risk and which will benefit the most. It was interesting, the way this panel is being run. It's a tumors put through. It's a multi-day process. And when we originally began talking to this, we were at about a 35-gene panel to go, and we increased that at the request of the clinicians to increase from 35 to 68 genes. Really was a nominal additional cost on the range of about 10% more than it would have been for 35 genes. And I think that you'll see that progressively go through in the future as we do whole exome and ultimately whole genome testing. It is getting cheaper and cheaper, and I think the value to be gained is tremendous. We also, as a pathology group, believe our portion of the personalized medicine concept is that we have a pathologist look at every tissue before it's done. We try to make sure that the part that's being analyzed is the optimum portion. Luckily, a lot of the secondary biopsies we have don't have any residual tumor in them. They've been partially treated, or a lot of it's necrotic. We go back, and one of my colleagues or I look at the tissue. And we've had some cases recently where we had to go back 3 or 4 times to find the pleural effusion that was positive a year and a half ago. And we're not just running blindly tissue that would be very, very low yield and worthless and misleading potentially. So we're taking that very seriously, and I think in a very cost-effective directional approach.
Your question also opens up the larger issue of whenever there's a new technology that holds a lot of promise, with the challenges in modern medicine and the financial pressures on everyone, most particularly the patient and their families, there's an ethical responsibility to introduce these things carefully and to carefully monitor the initial performance of whatever technology is being used. So on the one hand, we don't consider the panel itself. It's a test that anyone can order. There are panels of this type being offered around the country. But what is investigational, what is experimental, is the management of the information. So we've had the panel up available for a little over 2 months, but we're just completing the process of rolling out effectively an investigational protocol, a research protocol that is IRB approved, that is, will have regulatory approval. And it's essentially first getting permission from the person to collect the molecular signature information and to use that for the person's benefit to help select standard therapies, to help match to available clinical trials, but also to take some of that information anonymously without connection to the individual person and to use it to understand how this information on a population basis is helpful or not, in what circumstances, for data mining, as it's said. So I think it's, we're trying to be very transparent in the way that we approach this complex subject.
The other aspect that I would add to the cost issue is we're trying to be very sensitive to the time. With a new diagnosis of cancer, it's not fair to expect people to patiently wait while it may take 8 weeks for a result. The clinicians can't wait. They initiate therapy, may not be helpful therapy. That's why we're setting our goals and achieving them, I think, at a 10 to 14-day turnaround time so that you can begin the right therapy up front, if that's an option. We're also trying to, we spend a lot of time on the information management of, there's a ton of studies out there, but which ones are open, which ones are closed, which ones have pertinence to the specific tumors, and to give that data back to the clinicians, which are locally available or within a reasonable local character for the patients.
Dr. Kaplan, you had a comment.
One other thing, the cost issue is pertinent to the entire medical care system. The pharmaceutical industry, of course, is coming under enormous attack for truly outlandish cost of their drugs, as frankly some of us think, well, they should be. But even they are starting to get a lot more creative. We just signed an agreement with a major international pharmaceutical company where instead of doing individual trials with each of their drugs and this, that, or the other tumor, which takes zillions of years and kabillions of dollars, they are now making available to a number of centers around the country, of which we will be one. Listen, here's our whole panel of experimental drugs in our pipeline. If you identify a patient with a mutation that says any of our experimental drugs may work, not only will we give you the drug, but we'll pay you to test it for us. So everybody has to get into reorganizing how we do this. And that's the first big, I think, shot across the bow from the drug side. And there are other companies looking at doing the exact same thing. We've been involved in something called the I-SPY trial for a couple of years. Again, a consortium of drug companies trying to speed up the development of their drugs and cut the cost down. So everybody's going to get on the bandwagon. And although the test may be expensive, I think if this provokes this kind of reorganization of the medical industry, it'll wind up saving money rather than costing.
There was a question in the back. Yes.
Yeah, so you've been talking a lot about its usefulness after the diagnosis, but could you talk a little bit more about in the prevention setting? What's the tipping point for somebody that might come and utilize this sequencing who doesn't have a diagnosis yet, who's just concerned? Dr. Kaplan mentioned its usefulness for stratifying patients for mammography, for example. Those patients that haven't been diagnosed yet, but who needs, more frequent.
Right. So the question was, again, to repeat the question so everyone can hear, how this applies before a diagnosis of cancer. And I think it's an opportunity to clarify some technical aspects. So it's important to note that when we talk about the personalized medicine program and this this molecular signature that is being done with NGS technology. In this case, we're talking about a tumor specimen that's taken usually from a biopsy or a surgical procedure, and the cancer is literally embedded in paraffin, in wax. It's the paraffin-embedded tissue that the pathologists then work with. You can also, of course, look at one's molecular profile, one's genotype on either somatic tissue or germline tissue that's inherited, and that information can be used before diagnosis of cancer. But with that brief explanation, who would like to comment on the pre-diagnostic use, the pre-cancer diagnostic use of molecular genetic information? Please, that would be a great example.
You know, I think that the ideal sort of Star Trek version of this would be that we could all have our genome run from our inherited, from our cheek cells or from our blood, and know through some complex analysis that we are destined to have X, Y, or Z cancer at X, Y, or Z year in our life. That is not reality yet. There are certainly lots of companies out there that you can send a cheek swab to in the mail and get your genome analyzed, and they will give you some relative risk things in a variety of different disease states. All of that is basically commercially driven, not so much medically driven so far. And where that's all going to end up, I think is a really interesting and very big challenge for medical communities in general. One of the limitations from our perspective in doing that is, okay, so let's say I could tell you you're going to have breast cancer in 5 years. I don't have a single thing I can do about that. So we have a limit in the information that's available to us in how we could prevent things that are supposedly genetically somewhat at least predestined. We know that everything is a combination of our genetic makeup and our environmental exposures, but we really don't know specifically how that all goes together. So if I could then say, okay, I know you're going to have breast cancer, so you need to stop eating soy now, that would be lovely, except that's just not out there yet. So what we have is more early detection sorts of things and some stratification of risk where we have cancers that can be screened for more or less aggressively dependent on what your risk really is. In breast cancer, for instance, with BRCA mutations, women who know that they have a BRCA mutation have some very difficult decisions to make. They may choose to have preventative mastectomies before they get diagnosed. They may choose to have preventive oophorectomy before they ever get diagnosed, even though still not all of those women who are very high risk are going to get those diseases. So everything else is much more complicated than that, unfortunately.
Dr. Dawson.
I would say that we are currently in the business of risk identification, so we can identify what are risk factors for different types of cancer, and we're trying to get better about really identifying that, letting people know what their individual risks may be, giving them reminders about what appropriate screening might be for them based on their risk. And then we're in the business of risk reduction. Maybe the Star Trek thing in the future is that somebody will then be able to go in and tweak your genes so that it doesn't happen. But at this point, what we can do is we can reduce the risk through things like surgery, like prophylactic mastectomies or ovary removal or colon removal for people who are at very high risk for colon cancer.
I think the other perspective to take on your important question really relates to genetic counseling in all its form. And in the cancer world, that starts with some very simple information, family history in particular, to some degree one's personal habits. Obviously, if one uses tobacco products, they're immediately at a higher risk of having certain cancers. But there's a formalized genetic counseling approach that begins by collecting very clinical information, history, medical history as well as family history, and then deciding whether there's a need to obtain tissue for genetic analysis. Again, I think all of us appreciate that this is moving relatively quickly, and not in an exaggerated way. I think within a number of years, we will be looking routinely at the human genotype for certain bits of information in certain clinical settings. It'll be part of the routine approach. Other questions? Yes, Dr. Chu.
Just a quick comment. And for the cancer risk panel, it's an independent panel from the 68 gene panel Dr. Corwin just mentioned. So I just try to clarify a little bit. Hello? Can you hear me better? Hello? Yeah, thanks. So as Dr. Brown and Dr. Corwin mentioned, so the current available panel is targeting for the somatic tumor tissue, which really to see the molecular fingerprint, what happened already for the cancer tissue. And the question you just mentioned is the cancer risk, which the potential risks to develop develop cancer. So that's a different set of the gene. It's called the cancer kind of predisposition cancer panel. So that's where we're currently working on is 53 genes. And that only can explain very small portion of the cancer patient who have strong family history for certain cancer type. So the 53 gene we're currently working on is mainly target the breast cancer, colon cancer, pancreatic, and kidney. So which have certain gene already being identified. If mutant can lead to this high cancer risk. So that's panel we're currently working on, and hopefully maybe by the end of the year or early next year will be available to facilitate this personalized medicine program. So that's a two type of service. Thanks.
So again, the current panel, first of all, relates to tumor tissue, and it relates to collecting information that can be of help in managing that person's cancer challenge. There's the other issue of analyzing, quote unquote, normal tissue, or we use the term somatic or germline tissue would be another specific example, where we're looking at changes that occur in the body effectively that are usually inherited and can lead to cancer risk, and that's where you get into prevention strategies. So the team is putting together a panel for that purpose that will be drawn into the personalized medicine approach over time. Any other yes, in the back, Larry.
Two questions. One is how's that? Ooh,
that's excellent.
Nice. The database that correlates a mutation with what seems to be an effective treatment, is that national, global, local, institution-wide, and what's the future of those databases? And then my other question is, when you're seeing new patients now, are they coming in with some awareness and interest in genomic therapy, or is it still all new to them?
By the way, before we get into those important questions, many of you may not know Mr. Asher, but Larry is one of the key folks who helped us put together the very creative spots for the Swedish Cancer Institute that you may have seen on the television, to include one of our local Seahawks. With that point being made, does anyone want to comment on the database?
It's a huge problem. I've just been through this, a personal experience. We found a patient last year with a very unusual kind of neurological tumor for which there was no known treatment, and she turned out to have a mutation that no one would ever have expected her to have, but in fact we identified it. It was a mutation that is well known in other cancers. There was a drug for it. We treated her. She had a spectacular response, and my experience in trying to take advantage of this points out your question. I had to get on the telephone and start calling all over the country to find other institutions that worked with this kind of tumor. And here I am a year later still negotiating to try to put together a consortium of institutions to set this up as an organized program. This is a terrible problem. The FDA is working on it. The academic consortia are working on it. What you have at this point is different drug companies have their own databases of everything that happens with their targetable drugs, but there is not yet, to my knowledge, any kind of a national database to look at this. It has to happen. And the other thing is it has to happen at a great level of sophistication because one of the things that you discover as you start working in this field is there's not actually even very good standardization of what constitutes a mutation and what doesn't. As we put together the 68 gene panel, we're finding situations where a patient will come for another institution and we're being told it's been tested at institution X and they do or don't have the mutation. We get a different result. And it often comes down to technical problems. So all of this needs to be worked out. About the only place where this has become nationally obvious is in HER2/neu. I mentioned that earlier. That's a gene that's very, very common in breast cancer. We've been treating that target for 15 years. This year, 2 months ago, they finally came out with a national consensus on what constitutes a positive HER2/neu. So you're touching a very tender wire. Again, the entire drug development and governmental organization has to change to allow that to happen.
Yeah, that having been said, as Larry knows, we're in the process of launching a translational research IT informatics platform that will basically serve as the data warehouse as well as having the analytic capabilities that we need to figure out, for example, whether the information is helpful in selecting a clinical trial and selecting a standard of therapy that's commercially available, and then allowing us on a population basis to look at the anonymous data. And institutions like MD Anderson Cancer Center, the Moffitt Cancer Institute in Tampa, University of Pittsburgh Medical System, they're using the variation of the platform that we're anticipating making use of over time. What Hank was alluding to, the holy grail, if you will, of all of this is to have an information superhighway in the medical context. And you know, these things happen in steps and stages, and there are certain areas where standardization is happening, as in HER2/neu, but just as importantly is the universal communication that's not available at present. The second part of your question?
Yeah. So the second part of the question was about if patients are aware of this, and I'd say yes. Oftentimes when they ask, they don't quite know what they're asking for. But the truth is...
That's true of physicians as well.
There's there are a lot of commercial entities out there who do testing like this. And information is easily available to anybody who has a computer or a smartphone, for that matter. So I think most people, if they don't personally start researching what their new diagnosis is, somebody in their family does, and really very quickly they start asking about molecular testing and targeted therapies. And I think part of the incentive is because, you know, as I tell patients all the time, chemotherapy is not on anyone's bucket list. And so the whole idea of molecular therapy is that you can have treatment that doesn't involve chemo. And obviously that, at least from the outset, appears extremely attractive. It'd be nice if these drugs were all entirely non-toxic. Unfortunately, that isn't the case. But by and large, they don't have the same kinds of risks and side effects that chemotherapeutic drugs do. And they can be a lot more manageable in that regard.
And it really, the point that Dr. Wahl is making is so important. There's a refrain in cancer medicine: sometimes what you don't do is as important as what you do. And some of this molecular information nowadays, it may not point us to a drug that we know will work, but it might point us to a drug that we know will definitely not work. And that in itself is an important step.
From a pathology perspective, we've always regarded ourselves as physicians who deal with information. And I think that's becoming increasingly so with the broadest perspective of molecular medicine and pathology now. We actually, the testing itself is relatively fast, 5-7 days kind of turnaround for the instrumentation, the automation. The collection of relevant data that exists is exploding, the published data. And we actually outsource that to a commercial venture, Laboratories, who continuously is upgrading and updating their database that's relevant. So the results of the analysis are referenced out. That comes back, and it's still a morass of information that Dr. Berry actually goes through, and Dr. Hsu spends days sorting through what's relevant, what's truth, what has some potential bearing, and then that's taking longer or as long as the analysis itself. And hopefully that gets faster and faster and more solid. It's also the depth of evaluation that we do, and I think in our system we've intended it to be a very deep analysis of the genetic markers so that we're not identifying, or if we do identify, normal mutations that we all may have variable among us. That's important to know. That may not be the tumorous mutation that has any validity. Or if you find 1 or 2% mutation within the tumor, that's probably not the relevant element that you want to be going down the wrong path with. And so there's a tremendous amount of, first, explosion of information out there, and secondly, a tremendous amount of information that has to be collated even once we know that, to make sense of it. And that's why we've worked as hard on the information delivery package to the clinicians so that they're not sorting through 20 or 30 pages of possible trials, that only 2 or 3 or 4, and trying to select those that are actionable again. We really do view ourselves not so much as both a research but a clinically actionable panel of tests. And it's not just...
Are you saying we have shorter attention span?
No. No, but we don't want to mislead people, I think, of what might be out there, but really is probably worthless studies.
Yes?
If a person has a genetic factor that makes them likely to have cancer, yes. If a person has a genetic factor in their system that is likely to result in cancer, does that genetic factor go down to their children and grandchildren, or is it apt to stop with the person that has it?
The answer, and others can comment, the answer is sometimes. There are genetic changes that are inherited, and there are others that are not passed on. And this has to do with germline mutations as opposed to those that are not. Do others want to comment?
Yeah, that's exactly true. I think it's kind of interesting, though, because you have to wonder if a person's, let's say your cancer has a mutation in PDGFR. And so you kind of have to wonder, well, is there something else about you that made you able to get a mutation to PDGFR, right? It's really complex. But if a cancer has a mutation that is not in the germline, that isn't part of the person's background, that is not a heritable thing.
Okay. What inspired my question was my mother had cancer. My sister, first-line descendant, had cancer. Am I apt to pass that genetic factor down to my children?
Probably not, at least the way we understand it these days. It would depend maybe on if you're talking about breast cancer, and especially if you're talking about breast cancer in women who are young, it's possible then that you could have a mutation in BRCA1 or 2 that you don't get the cancer from and pass on at a 50-50 rate. But most other things, let's say your mom had colon cancer and your sister had pancreatic cancer, those are likely entirely unrelated, at least as we understand things today.
But I think the other comment about your question is that's exactly the kind of family history information that we were alluding to earlier, that in the hands of a genetic counselor or a genetic counseling team, or a physician who is adept at addressing genetic risk or risk issues in that context, taking that information and deciding whether there's any additional testing that is needed or not. There are some unusual syndromes that on first blush may not be apparent even to a good physician in terms of the family history.
Thank you.
We have a few more minutes. Yes, Jean, question, comment. Jean needs no microphone.
Thank you. I have had breast cancer, bilateral mastectomies, and developed a great toxicity to the chemo and all the new aromatase inhibitors, which are the drugs that prevent the production of estrogen. Is there any value to my going through and having a panel test with you if, in fact, you have my tissue, Dr. Corwin, and it's in wax and it's frozen? Is it worth bringing out to test for any information that could be gleaned, or am I just going one step too far cerebral that I need not take at this time?
Well, the way I'd like to have this question addressed, we have the perfect panel to address this. I'd like for each of our panelists to briefly answer that question and to see if there's consensus or not. Who would like to start? Dr. Wahl.
Well, Hank may have read more on this lately, but I am not aware currently of any genetic testing that predicts toxicity of AIs, or for that matter, unfortunately, response to AIs. So, tamoxifen.
AIs, by the way, are aromatase inhibitors. It's a hormonally related therapy.
Yeah, if we're talking, Gene, about toxicity of the drugs, that's correct. There are certain very specific drugs where these kinds of questions are relevant. For example, there's a drug called fluorouracil that you can have an inherited deficiency of an enzyme, so that if you give that drug to someone, you'd better reserve a bed in the intensive care unit for them. But by and large, for most of the drugs that are out there, we really don't have an ability to predict toxicity, or for that matter, to explain excessive toxicity for someone who gets it. They're just very rare, specific examples. As far as the hormonal drugs, as far as aromatase inhibitors, the answer is absolutely short. No, Tanya's absolutely right. The one thing that has been debated, an alternative hormonal therapy for someone in your setting might be tamoxifen. There's been a debate going on for at least the last 10 years. Tamoxifen is actually not an active drug. It's converted in the liver into an active drug, and that conversion is affected by multiple other drugs, particularly certain antidepressants. For about 3 years, people used to think that if you took an antidepressant, you couldn't have tamoxifen. Then we went through a period of a few more years where they measured a certain enzyme called CYP2D6. And if you had depressed levels of that enzyme, either because you took an antidepressant, because you're inherited with it, you shouldn't take tamoxifen. That's gone by the wayside now. All the data says that doesn't work either. And now the next thing people are looking at for tamoxifen is looking at blood levels of endotamoxifen, which is the active moiety, the active breakdown product, to see whether levels of that correlate. But that's still cutting-edge stuff. Short answer is no. But there are a lot of people working on it.
I think, the two quick comments. There is this burgeoning area of pharmacogenomics that is using this molecular genomic information to help us in managing drugs in some of the ways that were alluded to. But there's another level of your question that I think is very important, and that is for someone, let's say there's someone whose disease is in remission. They do not have active cancer, but Dr. Corwin does have their tissue stored away. Should that person have their tissue analyzed? And from my perspective, I'd like to hear other comments. I think the answer is usually not. I think unless there's a specific purpose, and it comes back to the responsibility, the economic responsibility that we all have to create a system that delivers care to all of our population with the proper emphasis and, a socially, ethically, economically responsible way.
There is one thing, though, that probably particularly for breast cancer is being worked on right now, and that is this concept of circulating tumor cells. We can now find small numbers of circulating tumor cells in the bloodstream, and there's data now emerging to say that if you can find these and quantitate that may predict who's going to relapse and who isn't. The question, of course, if that pans out, will be at what level do you trigger saying, oh, I better put this patient on some new treatment. So there's a lot going on with that, and it also brings up the other area that's very hot right now is most of the genetic stuff that's being done is being done on the tumor tissue itself. 2/3 of the biotech startup companies in the world are going to try to make their billions by being able to detect this in blood or in urine, so you don't have to biopsy people anymore to get this information.
Yes.
Is that also known as oncotyping? No.
Comment on oncotyping.
Genes come up in all sorts of ways, don't they? Oncotype is a commercially available assay of RNA, so that's sort of the pattern of what is going to be protein expression in a tumor that can predict better than just population-based statistics whether a breast cancer is going to A, relapse, and B, respond to chemotherapy. So that's it's a pretty useful test for quite a number of women who've had a breast cancer diagnosis. It's not applicable to all, unfortunately. And it doesn't exactly directly predict response to like an aromatase inhibitor or tamoxifen for that matter. I think the holy grail would be, as Hank was just saying, if there's a way to, when a patient has had curative surgery especially, to know for sure which patients are not going to relapse. Breast cancer is a great example because the vast majority don't relapse. And so right now, we treat everybody because we have the expectation that they could relapse. But if we knew that the 85% that we don't need to treat, they don't need to take an aromatase inhibitor. They're cured. They don't need chemotherapy. They're cured. That would save a ton of money.
And that's
and side effects and, emotional distress and everything else that goes along with that. It would be really lovely to know if you're on medicine, it is going to work for you and that you need it, and to know when you're not that you didn't.
And that really, in many ways, is the ultimate definition of a personalized medicine approach. You're trying to customize the approach so that it addresses the individual's specific needs, nothing more, nothing less. Yeah. We're just about out of time, but any remaining questions or comments? We probably have room for a question or two. Yes?
Did I understand that the testing is predominantly now for genomic testing, but through tumors? If you have to have a tumor, if you don't have, if you don't have a tumor, if you have another disease. I have a brother with ALS. Is there genomic testing that can be done to determine whether or not ALS is something they can discover?
I'll ask Dr. Shu to speak up on this also. I actually had a sister who had ALS also. I'm not aware of any genetic testing.
Only a very small fraction of the patient may have a genetic background that's inherited, but majority won't. But there has to look at the family history, like Dr. Brown said. For these testing, need to have the genetic counseling to look at the clinical indication and the family history to consider whether certain genetic testing can explain that specific.
But having said that, the oncologic testing is a small fraction of the broader spectrum of molecular genetic testing that's going on. Infectious disease is a huge application. Pharmacotherapeutics is becoming a huge application. Who's going to respond better to antidepressive drugs or antipsychotic drugs or antihypertensive or Lipitor, cardiovascular screening, women's health programs. This is a portion, oncology, of this broader array of genetic testing. Huntington's chorea is now detectable, von Willebrand, et cetera, et cetera, et cetera. Tons of genetically inheritable diseases, and that then broaches the ethical issue of, do you want to know or not? If there's nothing that can be done, I'm sure down the road, probably in my lifetime, Alzheimer's will be a pre-diagnosable entity, at least multiple entities maybe. But
There was one other question over here. Yes.
You talked about drugs. What about immunotherapy? Is there a place for that?
The question was, is there a place for immunotherapy? The short answer is absolutely, but let's elaborate a little bit.
Absolutely, at a number of different levels. At one level, many of the immunotherapies that are coming out are what we call HLA specific, meaning that you have to have a certain genetic makeup to be able to respond to an immunotherapy. So that's at one level you have this. At another level, some of the immunotherapies that are out there depend on the genomics of the tumor rather than the individual. The hot new thing is something called PD-1 blockers. Well, your tumor has to have a certain protein on the surface of the cell for those drugs to work. So genetics is critical in the patient's ability to respond to the immunologic agent, and the tumor genetics is critical to whether that agent will work even if you can respond to it.
There's also been a resurgence in interest in various vaccination approaches to cancer therapy, with some very interesting results in some cases in diseases where we wouldn't have imagined effectiveness. I'm a GI medical oncologist. There's some interest in vaccinations for diseases like pancreatic cancer, as an example. So again, it seems like for most of our professional lifetimes, people have been talking about the promise of immunotherapy, but step by step, there have been some very important recent discoveries. So I want to thank our excellent panel, Dr. Dawson, Dr. Kaplan, Dr. Wahl, Dr. Corwin, but most especially I want to thank each of you for being here and for your support. I know that our panelists will be here a few minutes, so if you would like to come down and talk some more, please do so, and I wish you all health.